Now, it's a great honor for me to introduce our keynote speaker, Dr. Roland Thorpe is a gerontologist and a social epidemiologist. He's nationally recognized for his expertise in minority, aging, men's health, and place-based disparities. He has a faculty appointment both in medicine and neurology and at the Johns Hopkins School of Medicine, as well as at Johns Hopkins Bloomberg School of Public Health. He's the program director for research on men's health and a member of the advisory committee on minority health with the U.S. Department of Health and Human Services. Dr. Thorpe.
So, good afternoon, everyone. I'm very excited to be here. First of all, I want to say thank you to Igor and the organizers. A big shout out to Lisa for consistently and persistently staying on me by getting things on time. And I apologize because I probably didn't make any one of them, but I really appreciate the hospitality that I've had since I've been back down south. I'm from Macon, Georgia. I'm from a line of Baptist preachers. I'm not one, but if I start to get loose today, somebody rein me in, all right? Go for it. Somebody rein me in. But what I want to just say is, this conversation that we were just having, I want us to frame my talk in this space, this time that we spend, because some of the points that you all were making are certainly in my talk. This is a first for me. This is the first time I've ever given a keynote presentation at the end of the talk. And what was beautiful about doing it was it affords me the opportunity to see what others are talking about and then to be able to comment on those things and look for things and talk about things that I think are different opportunities to push the field forward, to engage in additional ways in which we can collaborate and move forward. First, I also want to say thank you, Igor, for inviting me. And the other thing I want to say is that being able to come and have a conversation around a topic that's hot and present now, when you think about methodology and measurement, is really important. And it goes back to some of my disciplinary days. I do have a degree in statistics as well, so I appreciate your models and some of the models that I've seen along the way. So the next, I guess, half hour or so, spend my time with talking about, I'm going to give just a brief frame. We all know that AD, RD is a major public health burden. Then we'll talk about these social determinants that we've been talking about. And then when I go into talking about, I have 4 approaches I want to talk about that I think will advance our understanding of health disparities from a number of different ways. We're going to talk conceptually, then we're going to talk about some examples, examples as it relates to measurement. And then finally, I'll have some concluding thoughts and actually a call to action for this action group to see if we can take that up. So, and then I'm certainly open to question and answers and engaging into a dialogue at the end of the presentation. And I don't know who's timing me, but whoever's timing me, I think you might be timing. So give me the green light.
You got the keynote, you can have as much time as you want.
No, the keynote is longer too. So I want for us to, before I start, I also wanted to say that one of the most important, this is for the early career investigators in the room. One of the most important things that you can do is be engaged in things like this. To hear that conversation that we just had, to hear a lot of senior or established, I don't like the word senior, more established. As a gerontologist, I don't say older, say wiser, or established. As to hear the conversation and the things that they're grappling with is what we look for you all to take forth and move forward. Because I'm not going to speak for all of them. I plan on retiring. That's high on my agenda. So let's go ahead and get started. All right, so it's well known, this is a well-known fact that there's these huge stark differences between, as it relates to AD, RD, between Blacks and whites and Caucasians. That's very well known. And one most popular way to address these health disparities is through these social determinants of health that we've been all talking about for the last hour or so. And people do address these different ones. These are the ones that come from the CDC. These are the most popular ones that have been studied. And I would just want to say that these social determinants of health that we all talked about today, I just want to briefly point into, I really wanted to burst into the conversation, but I held back because I knew some of this was going to be in the talk. I have a different approach. What I heard in the room, I heard siloed people talking about things. And I think the way in which we're going to advance health disparities is to think about it from an interdisciplinary approach, right? I think I heard the conversation of people saying that we need to come together. I think the gentleman here said we need to come together and think about it all together, not just the omics data over here and the omics people doing their thing and the social people over here and social behavior scientists doing their thing. I think it's bringing people together at the center. And then I think bringing those together in an interdisciplinary way, we can actually push the boundaries of advancing health disparities, moving toward achieving health equity, particularly as it relates to ADRD. So I think when we think about these things, we need to be mindful of that and what does it take? And I also heard in the room that we had some conversation about, as it relates to data and the current shape of data, that there's no one perfect data set. And those data are going to have their biases. But you know what? For all of us who've come through our career, I don't know how many in the room has ever written a paper from a perfect data set. Raise your hand. Okay, now we get to it, right? So you see the point I'm making. And it's not, and science is meant to be the soul of science is replication and reproduction. So I think we think moving forward and keep building these building blocks, we are going to advance ourselves so we can grapple with the disparities around these around ADRD. In addition to these social determinants of health, I have this just to show you that 80% of the factors that influence health are linked to social determinants of health. So to think about studying disparities in ADRD in the absence of thinking about social determinants of health is a missed opportunity and it creates. So I think we must be mindful of that and just understand that being mindful of that, we're not all trained in an interdisciplinary way. That's why it's important to have conferences like this, where you have people from different disciplines to come together and to think about these problems. Okay, look, one of the key things I wanted to bring forth, and I want to touch on this very briefly, is that although we have these social determinants of health, I think someone stated earlier they have these systemic and structural drivers that are in place. One of the biggest things that we know that undergirds these social determinants of health is different forms of racism, largely structural racism, right? Before the unfortunate incident of George Floyd, it was very difficult to get funding to talk about these structures. And for those who were talking about individual choices and things, people's individual choices are constrained by the social structures for which they live. And so it's really important for people to think about these lived experiences. So when we're talking about lived experiences, I love the conversation we were having, talking about just a moment ago when we were talking about people walking and being in walkability. Well, the walkability in Macon, Georgia, where I'm from, is different than probably the walkability in Watts, where other people go. The different social environments and different structures in place that constrain their choices. I work in Baltimore and worked in Baltimore for 20 years. And one of the things we hear all the time from research participants, when you talk about activity, physical activity, they're afraid to walk outside because of the crime rates in their areas, right? And the crime rates, if you want to think about it, those crime rates are probably linked back to a larger structural issue. Why don't we have more policing in that area to make it safer? So I think we need, when we think about data and we think about these things that relate to ADRD, we need to be thinking about in a broad structure and how these things actually operate. And when we think about it from a broad structure, now my challenge to the methodologists in the room, how do we model that? How do we model that and have it in an inclusive way? And once we model that and have it in an inclusive way, how about trying this with you? Let's always write from an asset base. Let's not stigmatize the population from which we're studying. The Mexicans, Mexican Americans, African Americans, Asian Americans. When we study disparities, we oftentimes, 99% of the time, we're comparing them against whites. Why? Why is that? Does anybody really know? Right, nobody knows, we just do that. And another point, why 65? Why do we talk about 65 in a couple for somebody being old? I'll get to that one later on in the conversation.
But these are some things I think I would like to engage in when we get to question and answer. Because why is it that the white group, I have some suspicion of why it is. Be happy to share with you that time, but I'm saying these are some of the things that I think we're at a point in our research inquiry that we need to be able to start grappling with as we can further push the bounds of scientific inquiry. Here are just two examples of work that have linked place to ADRD. This is work coming out of Wisconsin, Amy Kahn's work, where many of us already know that she's linked in place, living in neighborhoods that are despondent, have impact on performance on cognitive tests, and also she's linked living in a disadvantaged neighborhood, has been associated with Alzheimer's disease neuropathology. These are just two examples of the work that's come out of her shop, linking place, one of the key social determinants of health, linking it to cognition, cognitive tests, as well as neuropathology. I think these are just two examples of what I wanted to highlight to show you how thinking about that neighborhood and going back and thinking about people living in certain neighborhoods, their individual choices are constrained, right? So when we talk about people living in their individual choices and going back to lifestyle factors, we certainly have to think about the broader context for which they're living in. If not, we're missing the point. And so I encourage everyone now, when we start to think about these individual characteristics, think about how they're constrained by where someone lives or their environments more broadly. I want us to keep that in mind and think about that. Now I want to start and go into the different approaches. There are 4 different approaches I want to talk to you about that I think is important for all of us to think about and in some form or fashion as it could help the methodology and how we think about approaching, addressing the disparities to move us toward dementia equity. The first one is I think we got to have better representation in minorities in research. And the examples I'm going to use are largely going to come from we focus on Black men because that's largely the work that I do. And so this is just an example of data from the National Health and Nutrition Survey. This is national data that's fielded by the National Center for Health Statistics. And I put this up, this is data from 2018. I didn't want to use data that was impacted by COVID, but this is data from 2018. I put this up just to make the point that when we think about if we're studying or we want to study minority men, or if we want to study men, if we want to study specific groups, then when we think about studying these groups and look at them age stratified, particularly if we're interested in late life, these numbers get very small. And I know as you all methodologists know, I don't think there's anyone in the room that's going to feel comfortable drawing emphasis on 89 or 61 individuals as it relates to making some plausible emphasis with respect to outcomes. But here's the thing, in 2018, there was an oversample. There was an oversample of Hispanics, example of African Americans, African Americans in these data. The problem is, while they oversample, it's great along race, but they don't oversample at other identities. And as we're becoming more heterogeneous across the country as it relates to race and other identities, we need to think about being sufficiently powered on the groups for which we want to study. That's very important for us to think about, particularly when we're thinking about ADRD. And in this context, thinking about older men, it gets really small for us to even think about doing anything. And this is national data. And so when we think about how do we address this and how do we move forward with focusing on data when our numbers are very small, I think the big one simple advice is to think if we're going to collect data ourselves, we need to make sure we're powered on the groups that we're interested in and any identities that we're interested in as well. Because this is just a clear example. They did oversample African Americans, but we still have small numbers at older ages. And we think about Black people. Another example, this is just the number of older Black men in the health and retirement survey with cognitive impairment. And we see that we think that when you're thinking about Roland, pull it together. When we're thinking about these numbers are fairly large, and I would feel confident around 420. But guess what? These are numbers of men who are cognitive impairment. But when we start to think about social demographic variables that oftentimes are missed, the sample size starts to decrease. Like many people don't complete information on income. And then they're dropped out of the sample, right? Or when you're trying to run a model, you lose those people unless you're someone who wants to impute. And I would love to have a conversation about imputation. I have a different philosophy on that. But if you don't impute, then your sample size can get much smaller depending on the question you have. So these are just some examples that I've been thinking about. I was working with a team of people, and we wanted to know how many Black men have been in cognitive intervention trials since 2000. We looked in the literature from simply starting the scope and review is from 2000 to 2020. This is what we found from our inclusion and exclusion criteria. We started out with 265 studies, and we ended up with 73 studies that fit our inclusion criteria. But you know what? Out of all of those, we found one study that focused, that had Black men and mentioned that they had Black men. One study. So what does that say about generalizability of some of the studies that we have now when we're thinking about understanding the health and well-being, particularly Black men? These are my examples with Black men, but I'm sure we could probably do something similar and find this for other groups of men, other groups of identities that people really are interested in. So we need to be thinking of that and be mindful when we think about what we're including people in these trials, and we're including people in the work that we're doing. We want to be really mindful of it, because if we don't find them be mindful, then we're going to be in a situation where the factors, we will not be able to develop new policies for the population. In addition to developing those new policies, we want to make sure that the Black men are getting the best quality care and the appropriate types of care. And then we finally want to be able to improve their efforts in primary and secondary prevention. So I think it's going to be really important for us to be able to think about that and underrepresenting this in clinical trials. This is just an example, like I said, for Black men, but there are other racial ethnic groups or other identity groups that are also are similar to this. And so I think we want to be mindful of that. One approach, popular approach, that could help us include the representatives in trials is CVPR, right? CVPR is a way that I think we can do is, but real quick, I gotta say this and I gotta move on. With CVPR, it takes time to build those relationships. And you gotta go build those relationships with those communities. I'm gonna say this twice, Carl. You gotta take time to build those relationships in those communities when there are no specific aims on the table. So you need to go engage that community, and don't go over there only when you gotta set a specific aim and you wanna do a study. You want to be able to engage them when you have specific aims, when you got money, and when you don't have money. Then that's the real true partnership of it. Enough of the days that we're running in saying that, oh, we got these specific aims. And by the way, those specific aims probably are meaningless to them because you worked on them yourself and you didn't even give them an opportunity to have a voice in the work that you want them to do. But yet you want them to be on your side. Think about this. Think about these things when you're potentially engaging new partners, or even if you're engaging partners that you have a sustained, established relationship with. If it's a different disease condition or something different that you haven't discussed, you need to be mindful and honorable of that to do that to them, because I think it's important for them to be able, and they should have a voice in this. One of the biggest things that we find that falls apart is we don't develop trust in these relationships. And it's important to develop trust when you think through the CVPR model. It's important to do these things and develop this trust and develop a partnership. It should be last long and sustained. And you should give them back something. That's really important, right? Giving back to them is really important. Going in, and by the way, don't give them no foolish, I'm not gonna get loose, I was gonna say another word, but don't give them a journal. They don't want that. Give them something they can use. So many times have I seen people say, oh, we wrote the article, we sent it to them. Or we wrote the article and told them where it is, and 99% of them can't get to the article because their organization has paid the hospital that we're able to pay at our retirement so we can get it free. We take all these things for granted, and we should not take them for granted. right? If we're really true to what we want to do and we talk about in this room, we're really true to helping advance in disparities in ADRD, we got to put in the work and roll up our sleeves and do the work. I know a lot of people in the room have done that because I've seen it through your talks today and yesterday, and I really applaud you on it. And so National Carl's office has done a great job with the Alzheimer's Association by developing partnerships. And I just wanted to bring this up because I think what he's done has been a Herculean effort. And I just wanted to acknowledge you and give you your flowers as it relates to this. Developing these partnerships are really important. And I think they are important. And that could be an example of how you may want to develop a partnership. There are also chapters of the Alzheimer's Association that are around that could help you. I run under the director of a Rickmark, A.E. Rickmark. We have in our community core people from the Maryland Alzheimer's Disease Association chapter, and they work with us to help us and to talk to our scholars on what it takes to develop relationships with communities and engage. So I think these things are important. Just some examples of what can be done if we just put forth and have a conversation. Now, the second thing I want to talk about is this idea of the importance of studying within group analysis, within group research. So this paper came out, I think in 2008, after Keith Whitfield, who was a faculty member here years ago. And we talked about the importance of studying within group analysis. So real simple. We spent a lot of time talking about studying disparities. But when you're studying disparities, you're comparing one group versus another group. But that's just telling us that there's a difference there. It doesn't afford us the opportunity to understand why that difference exists. One approach that I subscribe to that people could possibly do and could gain some interest is studying within groups. For example, we don't need another study to know that Black men have worse health outcomes than white men on a number of health outcome indicators. We don't need another study. Well, writing another study on many of those things merely just reifies the point that we already know that the difference exists, and it starts to stigmatize that population. Well, we don't need that. What we need to do, in my opinion, is we need to then study within groups. So study Black men and try to understand the mechanism and pathways that lead to that poor health among Black men. Then I think once we be able to do that, the idea conceptually would be is for them to better their health. And if we better their health, then the disparity would reduce, and ultimately what ideal would be for it to go away. So I'm a huge component of doing within group analysis. And I think people should consider the benefits of doing that. And I want to go through a couple of examples. I studied, how many people know this book? Great. This is my favorite book. And for the early career faculty members, I'll tell you, you got to have something that, and this is my favorite paragraph in the book. And what's in red is my faith, what drives me to do the work that I do, right? This book details, written in 1952 by Ralph Ellison, and this book depicts the young man in his contemporary life and the struggles that he was going through. I submit to you that if you read that book and take about 5 to 10 minutes of reflection of what's going on with Black men now, you would know if it's 1952 or 2024. And I think that's a sad state of affairs. Nevertheless, I think this is what keeps me going. And I know all this established investigators, we had time, we asked them what kept them going. There's something that keeps them going. That quote here, I'm invisible, understand simply because people refuse to see me. Hidden in plain sight, horrific health profile, but there's no real infrastructure at any standpoint, at any level that supports not just Black men, but men of color in general, right? So I think I look toward this when I'm doing my research because there are good days and there are bad days when you do your research. But the trick is to have your good days outnumber your bad days. That's what you have to do in whatever work you're doing. And there are days, I'll be simply honest with you, there are days where I'll be like, this is crazy. Why am I doing it? It feels like I'm beating my head up against the wall. But then I go back to this, and then I look at the people that are in my lab, and I say, that's why I'm doing it, because I'm trying to build a cadre of people to help push this forward. And I'm hopeful that at the end of this, I can build more people in the contract to think about methodology and measurement of how we move forward and improve the health and well-being. In my case, I'm saying Black men, but in any other person's case, it could be what group you're studying. Like Nick, it could be Mexican Americans in your case. So here, I put this up just merely to show you that Black men is still a public health problem. Black men still have a horrific health outcome, and I typically say they get sick earlier and they die younger than many other racial ethnic groups. But one of the key factors in them doing that is stress. Stress is a powerful component of that. And we don't think about it all the time. It's fundamental to poor health outcomes. But here's the question for you all. From a measurement standpoint, how do you measure stress? Is there a good way to measure stress? How have we been measuring stress, right? These are some of the things I think that we're serious about moving, particularly with ADRD now. When we know that, particularly among African Americans, it's largely mixed dementia, and we have these huge risk factors, such as hypertension and diabetes that strongly linked to cognitive decline and ADRD. And so I think it's important for us to think about how are we going to address those issues. And I think an opportunity is to think about a pathway. For me, the pathway I think about is stress for Black men. And that pathway may be something different from other people. And here is how I think of how stress, or at least perceived stress, actually activates these different behavioral and physiological responses that then lead to this cumulative chronic stress leads to this allostatic load, which then can impact organ systems and which leads to disease, differential disease states for different groups. And I just wanted to show you a case example real quick on some work that we did in the Gerontology Innovation and Aging Journal. We looked at the association between depressive symptoms and accumulation of stress among Black men in the health and retirement study. And what we did was we created allostatic load and we counted the number of indicators that were in the high risk area. And we used 4 as our cut. And so here we find that even in the fully adjusted model, we find that Black men who belong to in a high allostatic risk group have a higher prevalence of endorsing 3 or more depressive symptoms. So that shows that there is some type of association between this accumulation of stress and depressive symptoms. And so what we have a team of people that are now thinking about how best to move forward with these findings here. Another example I wanted to tell you about is a study that we're getting ready to launch. I have some multiple PIs. I have Dr. Shavonne Brown-Hughes is a multiple PI on this. And we're looking at the Black American United Memory and Aging study. This is a study that we're going to look at the synergistic effect of biological, environmental, social, and psychosocial factors, how they impact cognitive decline. And I think that's where we need to think about when we're looking at doing research in this area, thinking about the synergistic effect of those. It's a long time overdue for us to stop looking at things in siloed areas. So I think we know the siloed areas. The problem we have is that the people who do genetic work rarely talk to the people who do social behavior work, rarely talk to the methodologists. And I think if we bring people together, we're just going to be in a much better place. Monica, your work I admire because you do just that. You do all of it. You're in the community and you bring that other group of people together and then have this interdisciplinary team. So I just wanted to applaud you for the work that you've done and continue looking forward to the outstanding work. Our study has not yet launched. We're on the verge of launching. We have a wait list. This is just an example of our website and a letter that we have for our participation, and then people can join. One of the other things we do with this website, I think, is really cool. If we were to go under, resources, we have a Groove and Learn section. And in the Groove and Learn section, and in that section, we have small bits of educational information where people can go and learn about different things. They can email us and say, I want information on topic X. Then we go get information on topic X. And we make sure that information on topic X is in layman's term. We remove all the jargon, right? And we do that. And then there's a groove and move section where we have small 5-minute videos on small examples of how to do some low impact aerobic stuff like chair movements and things. So we're very excited about that. And actually I have to say, I was really concerned with people going to do the groove and move. And according to our click, people are at least going to and downloading the 5-minute videos that are there in place. One of the things I also want to say that even with the data that we have now, and even when we're talking about omics data, and we're talking about plugging omics data together with EHR data and all that, and linking it up to the census stuff, all that's great. But one of the things that we don't appreciate, particularly as it relates to Black men, that there are other factors that are known to influence health that we rarely account for. They're these psychosocial factors. And they're rarely in these national data sets. HRS has a few of them now because they have the lead behind psychosocial questionnaire. You know, there are some now in NHACs because they put them in there. But when we think about, these are a list of psychosocial factors that we have identified throughout the literature and in focus groups when talking to Black men over the years. That's oftentimes not in a lot of the data, right? Police brutality. I mean, we all well know the impact of that, right? But how many data sets is that in? How can we study that? Right? I talked about stress, medical mistrust, right? You want people to be able to study, particularly if you're going down south and trying to get some biomarker data, go down to Tuskegee. How about that? Try that on. Go down to Tuskegee and say, can I get some of your blood? The older men are gonna be really hesitant because of the United States Public Health Service study at Tuskegee. They're gonna really be hesitant about that. And I think we have to understand that. We know a lot about where you live and the social environmental conditions that people live under. We know that segregation, which has been used largely over the past decade, so it's a proxy for structural racism. But we know the social environmental conditions people live in absolutely impact people's health and well-being. We know that. That's well known, but so being able to link data to that, we can do that. And we had a talk earlier today about living in rural areas. We know that rural areas are absolutely different than urban areas. And the social determinants of health and how they unfold and play are absolutely different. And so to be able to think about how these things impact, but in my case, Black men's health is very important, but we don't have them in data. A lot of the data sets we don't have them. So if we say we need to collect more data, let's be mindful of what we're collecting and for whom we're collecting the data. And so that we can have the appropriate things in the data set to be able to have a more nuanced understanding of our findings and context around that finding. And so when I think about that, I think that the next area I think I wanted to briefly talk about, and we've talked about this, but I just wanted to make sure that this point is made. We want to be able to employ qualitative and mixed method. We just had a conversation around that. And it's so important. I think Dr. Milky said it earlier in her slides on the first day. She thinks that mixed method is going to be very important for the work that she's doing around biomarker collection of data. And I absolutely couldn't agree more. That I think is going to be important. And I think we all should embrace this idea because for me, what I'm really interested in knowing, not enough of you send in data surveys. Surveys are important, but I don't think surveys are the end all be it. And I think with the evolution of research and the evolution of analyses and methods that we have, we need to start bringing all of them to bear and have a robust conversation around the context of the numbers that we can provide. Because we mentioned, I think this gentleman here, I don't know your name, sir, but I think we talked about mixed methods and using mixed methods and qualitative research. I think that's really important. And I just want to pause here to say, even for the methodologists in the room, and you do all these different methods, which are innovative and important, what's really important if we want to drive change, is to be able to have a number that has context. So any group you study, you need to understand their history, their historical context. From when I studied Blacks, and I've studied Blacks and whites in the United States, I need to be able to understand what Jim Crow meant, what the Civil Rights Movement meant. With the Civil Rights Movement, were the policies in place, were they put in place, were they protected? Did they really help? I need to be able to understand that. So then talking to an older Black man that lived through these experiences and being able to interview him, being able to have that conversation with that knowledge, I think will bring out much richer conversation and much richer context around just a number. Just saying that these men are 40% higher, whatever the outcome is, I think those days are gone. I think it's incumbent upon us to take the extra effort. So just real quick, if you say you want to do this work, it's messy, it's hard, but it's doable. Richard say it's messy, it's hard, but it's doable. So we need some more money from y'all so that we can figure out how messy, how not to be messy, and make it more straightforward, and to continue making it doable, right? And core, we need money from y'all too. Don't think I was gonna call you out too. So, and I'd be happy to talk to both y'all, see how we can jointly find some of this stuff for the people in the room, right? But I think it's important for us to think about these things and appreciate these nuances as it relates to just put things in models and getting the number out, and without putting context around the number is a missed opportunity. It's merely a missed opportunity. So I just wanted to say that. And I think these lived experiences are really important to understand those. Okay. I thought I had it to lunch. No. I'm about done. The thing I wanted to say is that the other thing I think is very important is this life course perspective. We gotta employ a life course perspective when we're studying older adults. I think it's important because to understand that life course perspective does a couple things. One, it affords us an opportunity to be able to understand and assess the impact of whatever we're talking about. In this example, we're talking about racism, structural racism. We can understand the impact of structural racism, the timing of it, and the duration of it, and how it impacts cognitive decline or the continuum of cognitive decline leading to dementia. I think that's really important. Also, the data that we have now, I appreciate all the data we have now because I wrote papers on the data, and I think it's important around that. But the cohort studies that began at 65, they are oftentimes, they're less sensitive, right? Because we don't get information on early life experiences, right? Or if we do, we ask somebody to think back, and then we can be suffering, depending on how far back we ask, we might be suffering from recall. So we need to be mindful of that. And also, just real quick, Carl, you just don't show up at 65 and fall apart. You just show up at 65 and you just fall out. People just don't do that, right? And we don't capture information early on. We haven't captured information early on. And I think we need to start thinking about that. And why is it age 65 that we have to study that? You know, my understanding is because of the Social Security Act and when they put it at 65. But we all know that different racial ethnic groups, we know that they have earlier onset of diseases, and we should appreciate that, right? You know, HRS, I applaud them, they started at 50, but I argue that, you know, if you're studying a group that has earlier onset than that, you may, when you think about collecting data, you may want to think about moving your age group down. I think they mentioned our Ad Health data set. I think it provides an opportunity now. They had data early on when they were children, and now they were funded by NICHD at that time. Now I understand that this wave is funded by NIH. That may be a data set that affords you some opportunity to be able to look across the aging process and study aging process versus studying age. Okay. I'll skip through these. I'll go to the last thing I wanted to talk about is that we have to diversify this biomedical workforce. We have to if we're going to achieve equity. I think we have to increase the number of people of color and the number of people of different identities into studying this work. I think it only makes for a stronger and more robust enterprise. And then we want to make sure that we increase our training and provide translating our work to evidence. Because if we really want to make the impact, we have to be able to provide evidence-based work to move toward policy relevant solutions and help promote strategies. That's just what we have to do. And then when I talk about creating these interdisciplinary teams, we want to create interdisciplinary teams that we have people on the team that have expertise across these different areas of the health disparities framework. And then you start asking questions of how these things operate synergistically to impact performance on cognitive tests or to impact MCI or to impact dementia and neuropathology. So I close with, I think that we have to have greater interdisciplinary teams, and this is a good place to start to think about it. These better methodology approaches, we talked about some of that throughout the conference. Very excited to see where we are on that edge and that part as it relates to methodology. And I think a life course perspective will be very important so that you give the lived experiences. And I also think we need to think about how best to measure structural racism or structural discrimination to be able to directly measure in our work. We have a ton of people who have created some measures, and I think we're getting there. And then finally, my call to action to this group is I think that we should think about in the future, if we're going to do these things, or we might want to think about having a discussion at the end of each one of the sessions to talk about health disparities or how put this in the context of health disparities at the end of each section, because I thought that I heard some comments, there may have been an opportunity to put that in context. And the final thing I'll say is that how about we do this? How about we treat health equity and health disparity scholars like biostatisticians, put everyone on the team. I'll stop and I'll take questions. Those are the people whose shoulders I stand on. I appreciate NIA and all the other people for the funding. And if you want to get in contact with me, that's my contact. Yep, I knew you were going to have a question. Let's go.
Very, very nice, very appropriate style of presentation. Exactly what we need after 2 days of our hard work. Thank you.
Yep. You have a question?
No.
Everybody.
We have 2 more minutes or 3 minutes for the questions. So you have to.
Anybody have a question? Or for those who are going to be here? Yeah, what's the question, Carl?
No, I think it's a really good point about the, maybe the health equity scholar at the end of each panel session that provides some context that will center us on the race differences. Stress, it's come up a few times, and really appreciate that. But my question is to you and to the group. But we talked about disparities and social structural factors being foundational, and it takes a lot of time to change structures, right? And so in the meantime, we've got to find ways to give people information so that they can think about, modifying their lifestyle, right? Or health behaviors or, whatever, so, what are your thoughts on the practicality of, patient experience in people's lives and then the time it would take to, for example, redistribute wealth in the country?
So yeah, that's a tall order. That's a very tall order. But what I always say, my answer to that question is simply this. I don't think we need to be approaching redistributing wealth at the national level. Because the way things operate at the national level depends on who's in office and what gets prioritized. Simply put, that's what it is. But at the local level, you certainly can move forward, and your chances are a little greater, I think, at the local level when you're trying to maybe not redistribute wealth, but be able to reallocate some resources to be able to help people who are in more need. So you think about, I think about the city of Baltimore, and then we're thinking about one thing I haven't talked about, I didn't have time to talk about. One thing that we omit all the time is political determinants. We forget about political determinants, and we forget about them, and we only think about them every 2 to 4 years, right? And then we only think about them every 2 to 4 years for 6 months, and then on that 181st day, we go back to where we are, right? And so we need to think about what is it that about our political determinants? How can we make sure people, particularly in my home state of Georgia, how can we make sure they change the law on when people vote and not vote, right? Do these things to be able to, at the local level, to be able to have people in office that can reallocate resources to do things. So for instance, like Baltimore has a safe streets program. The program has been working well for a number of years. And so that is always a key thing that's on the mayor and the mayoral candidate in election season. Because that's something that they've always reallocated resources to and shown to be an effective program. Those are types of some of the things that I think of. Other things I think of the presentation that Monica you gave in Las Vegas and how to engage the community and inform the community of these types of things outside of this, JAMA article and Jared Policy article. Those are important for the early career. Those are really important. I'm not downplaying, but I'm saying that also they're important for you. But the impact that it's going to have on the person that really needs the help is going to be low compared to the impact it's going to have on your career. So just be mindful of that. Do we have time for another question? Yeah.
We can ask another question. Yeah, here.
Oh, yeah.
So I'm actually usually silent in these types of discussion because A, I'm a privileged white guy, and B, I'm German, which is even worse, right? So I just wanted to ask you, because your points are very well taken, I think, and they are very important, but I think we can learn from them also when we think about studies done in non-Hispanic whites, right? Because what we do know is that the studies that we recruit actually always are enriched for people with better education, higher socioeconomic status, and so on. So I think these variables are very important also for these studies, because if we want to increase comparability, then we also have to select suitable comparable groups also for the non-Hispanic whites. So that's something that I take from this, and I think that's a very important point. The only thing that I disagree with to some extent is I'm a multi-omics guy. So I'm really focusing on the molecular mechanisms, right? And so you said that we should focus not on comparisons between the different groups, but we should also focus on within group studies. I do agree with that, but I would argue as long as we have the hope that we might find actually a treatment that works for all, be it one drug or a drug combination, then we also need the comparison in order to identify the common molecular mechanisms that are there for all of the different groups, right? Such that we can get to this unique treatment that actually fits all, if that is even a thing that is there.
So I'm gonna say this real quick because I can go on and on about that. So let me unpack real quick. I appreciate your comment, right? Here's the thing. When you're thinking about studying and looking at molecular level, you're talking about trials, we don't even have enough people of color in them anyway to do what you want to do. So we have to back up to get the number of people that are in there, right? And here's another thing that I didn't bring up that I think is important for all of us to consider. When we're doing clinical trials, the problem with clinical trials is that the exclusion criteria is so restrictive, we knock out people who really need to be in the trial. For instance, black people are obese. Black people tend to have high rates of diabetes and hypertension. Those are three top inclusion criteria in a lot of AD trials. So they keep out. So how are we ever going to really compare? What I think we need to do is we need to appreciate that. And there are other groups that can have different things we need to appreciate. And how about having a study design for the methodology that we can have an arm that has the criteria that we want, have another arm that has the people in there that have diabetes and hypertension. Because if you're really making that drug for them, you got to make the drug for the people and their contraindications before the medication for which they're taking. That's just real quick. I could have done this longer, but that's just real quick. So I do appreciate the point that you're saying, and I do appreciate the fact that you're talking about comparison. But I think before we even have a conversation you're talking about, we got to get a number of people in the study, and we got to get the study design right. And I think we need to have an arm because that's the lived experience. And that's one way I think we can think about capturing a lived experience in a study. And I think that's what we should think about doing. Have a group of people who have these areas that we got, put them in the study, and then you can test it. And then you see if the dose amount is appropriate for people with the condition. You can get to test that. You don't have to wait till you get to the doctor's office. All right, take this. And if it don't work, email me back through my chart. We're going to redose you, come back in, give you another blood test. We're going to get the blood, we're going to redose you. We can start learning some of that in the field. But I really appreciate your question. Thank you very much.